Can you see you can see my screen, everybody? Maybe you'll have to answer for the group, Rick. Is it showing up okay?
I
Yes.
see it fine.
Good.
It's fine.
Okay, good. Thanks. So the public option, what is it? Well, it's a way to include, or proposed way to include more people that are now included under Medicaid or Medicare, giving them an option to buy into those two systems that have fairly good reputation. Medicare has been here since 1965. People would not ever want to give that up. Medicaid, even though it has the sort of stigma of being a program for the poor people, it has done very well in states that have accepted it. So this would give, the public option would give the chance for people to voluntarily pay a premium to become part of two programs, public programs that are considered pretty good. But how many would it help? A relatively small number of people would be enrolled. And so in Oregon, there is an Oregon version of public options being considered. I think it could be as much as 20,000 or 28,000 people out of how many? 4 million? So a relatively small number. It would have limited bargaining power. And it's likely that the sickest of our population would sign up for it because they can't afford the premiums under private insurance. And they would be essentially in a high risk pool. And like any other insurance plans, if you somehow attract the costliest and the sickest groups, the premiums will have to go up. And it's called a death spiral. The sicker, more costly patients cause the premiums to go up. Fewer people can afford to pay those premiums, and the system fails. And there's already been examples of that with healthcare cooperatives that were started up after the Affordable Care Act was passed in 2010. It would not allow many of the advantages of a true single payer. There would not be the bargaining power or the because it's just one more insurance plan among many. And not only that, it's sort of an innocent egalitarian baby swimming amongst in a pool of sharks. And not to demean the insurance industry, but they have to know how to avoid signing up patients that are going to be costly. If they don't, they go out of business. So if you're the CEO and you see that your costs are going up because you're providing more care, you're likely to lose your job. You could even be sued for not promoting the corporation's well-being. So there's a number of reasons that just adding one more insurance plan, now we call it a public plan, would not benefit very many people and certainly would not reduce costs. So that's the next slide. Would it help reduce costs? There's no reason to think it would. So several studies have shown that up to 30% of the procedures that we do are either unnecessary or even harmful. And so just adding another insurance plan, public option, would not do anything to correct that problem. In order to correct that, there has to be transformative change where the public has more control over what is covered and how much it should cost. And it would try to get unnecessary middle people out of the system. But the public option does none of that. It would not reduce the amount of sort of infighting, trying to get paid. It would not reduce the overhead, administrative overhead of multiple insurance plans that's so costly. And for hospitals, there's a 25% administrative overhead. Just dealing with hundreds of insurance companies and not only just the companies, but each company has a number of plans. You know about bronze and silver and platinum and so on. So all of these have to be taken into account when the hospital bills. So for Canada, the administrative overhead is more like 12%. This does nothing to create a drug formulary, which would be a more predictable way to determine costs, knowing what drugs are actually need to be covered and which ones don't. So there's no real potential for a public option to improve efficiency or reduce waste. Well, would it be more affordable to those greatest in need? Well, probably not, because this would still require paying a premium. And here's this delicate balance. If you make the premium low enough to make it affordable, that means paying providers low enough that they may not be willing to even see patients. And that's already true for many Medicaid patients and even Medicare. So no, these people who have lost their jobs, who were already having trouble meeting premiums, would now be asked to pay another premium for this public option, and they probably would not be able to afford it. Obviously, public option would do nothing to disrupt the current dependence on employees on their job for their access to healthcare. I think we're all pretty familiar with the irony of people losing their jobs, especially during the pandemic. And at the time they need access to healthcare most, they lose their access. If you could picture a boardroom of very sinister planners and they wanted to come up with the worst possible scenario, this would be it. They've done it. We've done it. But would it help those who already have insurance? No. Many people who already have insurance can't use it because the deductibles and the copays are too high. That's as many as 30% of people who have insurance can't afford to use it. And adding just another public option doesn't correct that. So I think we all kind of know what a better solution would be. And we also know that Congress in its current formation, and even our new administration, is going to be unlikely to enact a Medicare for All bill soon. It is encouraging to know that the 2021 version of the Medicare for All bills that were introduced in 2019 will be reintroduced this week. It's supposed to be Wednesday, by Representative Jayapal from Washington. She's introducing the current version of HR 1384, which I think by most critics is the best bill that there has ever been towards universal health care. And Senator Bernie Sanders will reintroduce Senate Bill 1129, the current version of that. Sanders has very few co-sponsors, and we would like him to modify his bill to look much more like the House bill, which is much more restrictive on insurance companies getting their nose under the tent than Sanders' bill is. But Sanders is in this difficult position of having so few co-sponsors that if he modifies his bill to make it more strict, he'll lose even those co-sponsors. So he's in a tough spot. So that's where Congress is. And of course, we all know that President Biden campaigned against universal health care. He wants to trust the idea of improving the Affordable Care Act. And as you will see later, bolstering the insurance industry by helping people pay premiums to the insurance industry. So this has been a windfall for the insurance industry. Affordable Care Act was, and this new bill that was passed also is a windfall for the insurance industry. So you may know that Oregon is pursuing its own version of a universal healthcare system. And I'll stop share screen so that I can now ask you again, how much do you want to know about that? And do you have questions in mind, or have you already been involved in following it? Just open up for discussion. Nadine?
I have a question about the public option. I'm wondering who's promoting the public option? You know, who are the backers?
Well, President Biden and probably most of the mainstream Democrats. The original Affordable Care Act was to have a public option included in it. President Obama wanted that to be part of it, but the insurance industry fought it and got it out of the Affordable Care Act. So now, over time, the insurance industry is getting more of its money through public plans like Medicare Advantage and franchises of Medicaid, like our local intercommunity health network is actually operated by a private nonprofit, the Samaritan. And so the mood has changed a little bit, and the public option would still be a source of income for the insurance industry. So they might not fight it as hard. And they certainly were behind this COVID bill that was just passed because it's a windfall for the insurance industry. In other words, it's subsidizing your and my, if our income is low enough, your and my premiums so that we can buy private insurance. So I don't know if I'm getting close to the answer there, but
no, it's very helpful. Thank you.
No, Paula?
Yeah, I guess I always understood the public option to be allowing people to buy into Medicare or Medicaid. So apparently I misunderstood that, because you're saying it would be a whole separate insurance plan that would be a public option.
Well, there's various nuances in option. Yes, buying into Medicaid would be a form of a public option. So what happens now is if you, as a single individual, earn $16,000 a year, you qualify and you establish your primary care and you're fine. But next year you earn 18,000 and you are dropped, you don't qualify anymore. And that's called churning in and out of coverage. It's very disruptive. Some people have incomes that vary throughout the year, and notably artists might be very busy in December and November, but in July and June for holidays and then weddings, but have very little income in between. So they jump in and out, and it's doing that process means you lose your access to your provider and you have to go find another one if you now are on a private plan. So there is that would be helpful for that population, and it is small, 28,000 compared to 4 million. But it still involves a fiscal cliff because it's instead of qualifying at 138% of the federal poverty level, maybe you qualify up to 200% or 300%, but there's still a fiscal cliff even for that. So it doesn't really get rid of churning. But okay, and the same thing is proposed for Medicare. Some of the presidential candidates, Buttigieg in particular, said Medicare for all if you want it. And if you don't get everybody in the pool, healthy and unhealthy, it's not going to work, because that's the same problem with the death spiral. You get all the high cost, sickest patients going to the plan that you gravitate to if you can't afford premiums. So that would be another form of a public option.
These various groups, whatever, negative selection has always been the bane of the insurance industry. If they can take all the sickies and get them out and issue a new edition to get healthy people on and let others go by the wayside. I'm speaking with 42 years in the insurance business and seeing what's been going on.
Yeah. And you can't blame them. I mean, if you were a CEO of an insurance company, you wouldn't be there very long if you didn't really know how really well to cherry pick and lemon drop. Your business would fail. It's not that they're evil people. It's just that our healthcare system doesn't need them to sort of dig holes in the pavement and then fill them up at very high cost. That's basically what they do for us.
And being admittedly a Bernie supporter virtually all the way, and on the outside looking into a lot of what's happened, it's just the overhead alone for the private insurance companies to administer all the bills and statements, and this is covered and that isn't covered. It's such a huge waste of money that could be done so much expeditiously. And I'm sounding like Bernie here right now. Take the people who become unemployed for processing all this stuff and find jobs for them within the insurance industry itself and other capacities. Don't just say we're going to lay off a whole bunch of people because we simplified it. Obviously, if they do that, then something's wrong anyway. So I'm still an advocate of Bernie's plans. Not going to come through that way. In fact, probably what's going to happen, my opinion, is it's going to ultimately be a state by state, like it did by province in Canada. But we're taking the steps in the first direction. And while I'm spouting off here, what's going to happen when the birds come home to roost? COVID is by the wayside pretty much, and millions and billions of dollars have been shelled out by hospitals on people who have COVID who don't have any insurance. Is going to be a day of reckoning in the fall of next year. What do you think about what's going to happen then?
Well, my dire concern has been for quite a while that our system will have to collapse before it will renovate itself. And we didn't have the crisis or the damage of war on our own lands like the European countries and other countries did, which forced them to turn to government, as they did in England and so on. We haven't had that experience, but we may have to go through something similar, unfortunately, because 17% of our gross domestic product is healthcare related, and it's too big to fail in a way until it fails, and then we'll have to build from the bottom up. I'm hoping we can build enough wisdom to prevent that.
We also have the long haulers, which are, don't know how many, but that could really hurt.
Oh, we lost you, Don.
I'm saying that we have the long haulers, and we don't know how long that'll be and what effects and how many, but that could really take care of Social Security disability just like that.
Mm-hmm. Mm-hmm. So a number of states are working towards their own universal healthcare systems. Washington is headed towards a ballot measure in 2021, even maybe. And several in our Mid-Valley Healthcare Group have looked at it and think it's pretty well written. California has had 3 close calls of passing single payer in the past 30 years, and now has another single payer bill that's being introduced. Maine, Vermont, people look at Vermont as it was going to be the lead state, and what they did wrong there was not include the funding. How would you fund this and get that way up in front of the public to talk about it? And when it turned out at the end that it looked like it was going to be an 11% tax, income tax, that just frightened everybody, especially business. Well, what they didn't emphasize is that they were already paying the equivalent of 14% tax uh, through the private insurances. So we have to learn from that. But many states are headed that way, and maybe we can do it as a region if we keep talking with each other, West Coast region. We can spend a little time on the COVID relief bill if you'd like.
Before we change to that, can I ask a couple of questions about public option? In 2009, when they first started talking about the public option, after basically saying single payer was off the table, Chuck Schumer said in response to Republican concerns that the public option was a backdoor way to single payer. He said, this public option will not compete with private health care. And somehow the people that were pushing the public option managed to convince their followers that this would lead to single payer because it would be so much better, everybody buy into it. Well, if it costs more to begin with, I'm not sure who to attract in the first place.
Yeah.
But if somehow sicker people could only afford that more expensive plan, it made no sense whatsoever.
No.
I mean, why it came so close to passing is beyond me, because if it would have passed, it would have been just shown how ridiculous the whole idea was. And it only lost by 1 vote. So how would this be different? I mean, they're talking about it again. Have they said anything about how this would be different from that ridiculous idea?
Well, I can't answer that directly. I just know that in 2010, even though the public option would have helped the insurance industry, it would have brought more income. They must have felt that opposing it altogether would be even better for them. Now I think they're more in a position that the public mood is for Medicare for all. The polling is strong for it. During the presidential campaign, that's one of the main topics. They also have shifted how they get most of their income. It's no longer single plans, private indemnity. It's increasingly through Medicare and Medicaid. Those dynamics may make support of a public option, and particularly this COVID bill, much more desirable than it was in 2010.
So this would be more like Medicare Advantage for anybody who wants it.
Yeah.
Okay. And they make, like you said, the insurance companies in your last talk are now making something like 70% on average of their profits is coming from Medicare Advantage.
I forgot the number, but it's big. It's the fastest growing part of private insurance now is the public plans.
Right.
You could see on television for all the ads and everything to sign up for Medicare Advantage plans and this and that. And are you getting all that you deserve? Oh, my Lord, just laying it on thick. And I imagine the churning plans out there too for whoever sells it from one company to another.
Oh, yeah.
The government loves it, makes it sound like it's totally legitimate.
Yep. Yeah. With the last administration, the CMS websites were, almost advertisements for Medicare Advantage. Don, you had your hand up for a little bit.
I need to leave. I have another appointment.
Oh, okay.
A ways away. So thank you for all of this. I appreciate it, Rick and Mike.
All right.
Very nice.
Thanks for coming, Don. I had another question. You mentioned that premiums, excuse me, even if it was a Medicare buy-in system, that premiums would still be individually determined, whereas in Medicare now, it's just income based. The premiums, and they're pretty low, whatever your income is.
Yeah.
Is that for sure, or have they talked about subsidizing the premiums in the public option plan so that wouldn't happen? I mean, after all, the government's got all the money they need for war, so why can't they just throw more and more at the insurance companies?
Well, various states have taken that action of including more people to a higher level of the federal poverty level. I think Oregon is at 138%, whereas many states are right at the federal poverty level. Why wouldn't we want to? Well, that's what the new COVID bill does, is actually throws money to everyone who's paying any premiums. So that is a route that has appealed to Congress. And of course, it leaves the insurance industry right in the middle of catching that money before it doles out what it wants to, whether it's through the public option or Medicare Advantage. So it's not a good situation.
And that's not an option that the state government has. They can't invent money out of thin air, throw it to the program. They
That's
have to
right.
stick to a budget.
That's right. I did mention that Oregon does have its public option bill. I think it's HR or HB 2010, and it was to have had a hearing this coming week, but it was taken off the schedule for the House Healthcare Committee, and I wouldn't be surprised if it's because of the generosity in the COVID relief bill that makes a state public option unnecessary.
This
Thank you.
morning I woke up, checked the computer, and by golly, we have had our money show up in the account from the feds already. For those who get direct payment, you know what I mean, have your refund checks go right to a checking account. Never thought it would come in so handy 3 or 4 years ago when they started allowing that, but it's those people who did it lucked out.
Yeah. Any other questions about public option or state plans?
Well, I guess I have one other question. You said that it wouldn't really be any more efficient, and I'm a little confused about that, because if it was a Medicare or Medicaid, those are substantially more efficient than private plans, even despite the fact we have a multi-payer system. So why can't they keep that as efficient, even if it is going to eventually fail?
So the question of if Medicare can do it, why not a public option? Well, Medicare is a single risk pool that doesn't have to compete with 100 other insurance companies on its own. That's traditional Medicare. Of course, the door was open to privatize Medicare through Medicare Advantage. That's a separate issue. But I don't know if I'm getting close to your question, Rick.
Yeah, you've mentioned part of it. I mean, if they're private plans, then they're going to do their usual tricks of not paying everything and having to duplicate, triplicate, go through a big paper shuffle before they'll pay anything. That's one inefficiency. Sure,
That's right.
I can see that.
So the public option would be just one more plan among 100, not addressing the very problem, which is the complexity and confusion that the whole system involves. So go ahead, Paula.
No, oh, go ahead. Go ahead, Paula. I have a question too.
Oh, okay. So let's say that Oregon gets the universal health care for all plan in place, would people who are currently on Medicare or Medicaid or Medicare Advantage plans, they would not be eligible to join that, or is that correct?
The bill, as it stated, would do its best to include everybody. The Washington bill excludes Medicare and the Indian Health Services. For any state to include Medicare, it would have to get a congressional waiver. And there are bills pending to allow that. One is HR 5010 that would allow sort of a super waiver to get around the problem of how can states use Medicare money, because that's controlled federally unless they pass the waiver. and how to get around ERISA, the Employee Retirement Insurance, I forget the rest of the SNA, which was passed in 1974 to protect employees' retirement pensions from being fiddled with by states. And, you know, it was a good bill for its purpose, but now it has one of those unintended consequences, is that the states cannot require retirees or employees to submit to a certain healthcare system. That would be messing with their guaranteed benefits. Of course, that doesn't at all account for all the pensions that have simply disappeared because companies declare bankruptcy. ERISA didn't help that situation, which is pretty common, to my understanding anyway. So those two things would have to be waived, but there are bills, and we have our federal legislators are in favor of it. I think even Wyden, who's been the most resistant and has not yet signed on to Medicare for All, Merkley has, DeFazio has, Blumenauer and Bonamici have. Schrader has not, and Bentz, of course, unlikely to also. Was it Susan that was the next?
Yeah, I just want to follow up on Rick's question, because I'm also a little bit confused. If the public option is a Medicare option, why wouldn't that be just as advantageous as our present Medicare and people that are on it, as far as coverage and premiums and everything else?
Well, it would help that segment. Let's say they drop the Medicare age to 55.
Yeah,
It would help that group, but it wouldn't solve any of the other things that make single payer so desirable.
Right.
Getting rid of the complexity, the confusion, the administrative overhead. So I wouldn't.
If I could add one thing, Mike, the other thing is the premium is not predetermined. It depends on your health conditions. So they could charge whatever they want, just like they can under Obamacare, based on your individual conditions. It's really not the same thing. They're getting the benefits of Medicare, but they're paying more. Isn't that right, Mike? Or am I misunderstanding?
If they had to buy in, whether they would be actuarially rated. So right now with the Affordable Care Act, you cannot be punished for having illness, at least not if you're applying, and that means the insurance company has to accept you. But what they do, which is just as restrictive, is if you have chronic illness and need specialized care, they can say, oh, I'm sorry, that care is not within our network. In fact, they took Cedars of Sinai and UCLA off of the Aetna coverage down in Southern California for that very reason. Narrow networks, pre-authorizations, all of that comes back in, even though they can't deny out of the starting blocks, they can't deny you, but they can sure make it hard on you and make you drop out if you have chronic long-term illness.
Can't they also charge you more though? That was my understanding.
I don't remember. Now, if you buy a supplement, let's say you had Medicare Advantage and you got upset with it and you wanted to go buy a supplement, like, I don't know if you can call them Plan F, G, and so forth, then I think they can rate you for what risk you have coming on. But as an initial applicant for either Medicare Advantage or traditional Medicare, I don't think they can use risk rating on you. That's the big crown on the Affordable Care Act.
Well, I guess that's where I'm getting confused, and maybe that's also true of Susan. Even though they're buying Medicare benefits, are they guaranteed under the current proposals that they won't pay any more than current Medicare recipients? Because I thought since it's a buy-in rather than a guaranteed right, that they would be actuarially determined.
Yeah, I don't know the answer to that. Say if they expanded Medicare down to age 55, would the
Yeah,
premium,
that would be different. Yeah.
Would the premiums be risk related? And I don't know the answer to that, but I do know that if you apply for a supplement after you've been on Medicare Advantage, they can restrict you by risk and charge you more.
Sure. Okay, thank you.
So we can spend a little time on the new COVID bill. Everybody see the screen?
Yes.
Okay.
Yes.
So this has been a big deal, obviously, and it's going to make insurance more affordable than it has for 10 years. It would spend $34 billion to help Americans who now buy insurance on the marketplace. I don't like that word, marketplace. And it would last through 2022. And basically, it would throw a lifeline to low and middle income Americans who have fallen through the cracks. And for example, a woman who has lost her job is facing $10,000 in premiums, and who knows what the deductible is. It may not be even a reasonable deductible, but and her income is $3,000 right now. Before the COVID bill, her income was $3,000 too much for her to qualify for the ACA subsidies that could have reduced her premiums from 10,000 down to 3,000. Now, with the new bill, she would qualify. So that's life and death, basically. Your total income is, $30,000, and you're paying 10,000 for premiums. You can't live. So there's other examples of how it would help families with tax credits and so forth. And most of the nearly 14 million people enrolled in plans on the marketplace would end up paying less under the new bill. And it would add another 1.7 million people to enroll in the exchanges. So it's got a lot of good things individually for people to get better chance of getting healthcare. It's just that it's just paying this huge burden of money that ends up in the profits and complexity of the insurance industry. Let's see, it's also going to pick up 100% of the cost of premiums on Cobra. And has everybody heard about Cobra? Yeah, it's aptly named. I forgot what the acronym, what the acronym really stands for, but it's once you have had insurance through your employer and you lose your job, you can apply for coverage at the same set of benefits, but you have to pay the full premium, not just what you were paying before, but what the employer was paying. Well, people can't afford that. And so it's basically a high risk pool that people can't afford. So now they're sugarcoating that by saying, oh, let's have all of the taxpayers pay that now. So again, it's going to help a certain select group of people, and unions are behind this because they can see that it was a quick and easy step that benefits union members right away. But it still offloads this huge pile of money to the insurance industry.
Doesn't Cobra have a time limit, like 2 years, 3 years or something?
Yeah. So it's limited also.
Is it that long? I thought it was only 9 months or something.
you could be right. I never sold health insurance, so I can feel good about that. I did a lot of other stuff in the insurance industry, but never got involved in that except disability and long-term care. So
There's probably nobody that can afford it for 9 months anyway if they don't have a job.
Yeah. So I don't know what the final bill would have come out with, whether it's 85% or 100% coverage of Cobra, but that is another windfall for the insurance industry. That's basically what's in that recovery bill related to healthcare. Does that bring any questions to mind?
I'm sorry, go ahead, Paula.
I was just wondering if the relief bill affects the premiums that companies are charged for their employees.
I don't know that. That's a good question. I'll see if I can find out.
Because I'm curious then about whether the employees would continue paying as much as what they currently are, or if their premiums would also be reduced potentially.
Well,
Because I know like my daughter, for example, gets insurance through her work, and the premiums they pay just for modest coverage is, astronomical based on her income.
Uh-huh. Is it a self-employed insurance plan?
No, it's through her employer, and it's with a company. I don't know whether it's Blue Cross, one of those types of companies. The company she works for determines what insurance company they work with. They have no options there. It's their only option is the silver or the gold or platinum plan, and the silver plan has almost no coverage of anything, and the platinum plan is way beyond anybody's reach that works for the company. So they all take the middle road, but it's still extremely expensive for them.
Right. I don't know in what way this would help employers or employees of self-insured companies, which
Yeah.
half of them are, like Samaritan is self-insured. That means that their employees are primarily covered by Samaritan, but the handling of the bills is by a contracted insurance company. That's my understanding anyway. So in those situations, I don't know whether this bill, and I'll try to find out how it's going to help companies that are self-insured.
Well, or yeah, they're not necessarily self-insured, but either way.
But if she's paying a premium, it seems to me that all of this implies that she would get a benefit.
Well, or at least have the option then of going on the public market, which would be subsidized versus getting insurance through the employer.
Right.
Mike, I had a question too. When you were talking about the costs of subsidizing the insurance industry, I didn't hear you mention Medicaid. It isn't the insurance industry, but it does cost the government money. And when we had this huge expansion, part of the deal was that the government after the first year would still pay, they're still paying 90% of the expansion, aren't they? And so now that on top of that, they're offering, they were paying something before, so can't count all that, but now they're offering incentives on top of that for the states that haven't already accepted it.
Yeah, I've read that. I can't speak knowledgeably about how much that encouragement is in form of money, but that's another good point. Yeah,
yeah, I mean, even the Medicaid, even get the subsidy, the original subsidies, the Medicaid, that's a lot of money too.
Yeah.
And if all 50 states take it, it's going to be just a ton of money. And that's, I don't hear people talk about that much, but it's another cost.
Yeah. So I would encourage everybody to, and I'll send the links to the Oregon Universal Healthcare Task Force. They are really seeking public input. That they're just like you me. There are what, 20 people on that task force. 13 of them are voting members. Ed Junkins is one of them, who's on the Corvallis City Council, and also an assistant dean over at the medical school in Lebanon. Good, wonderful people, sharp as a tack, but they're just like you and me in terms of dealing with this avalanche of information, to come up with a plan that they'll propose to the legislature. But they do need to hear from us. As you may recall, when the Oregon Health Plan was designed in the mid-90s, all the experts got together and put what they thought was the right priority list for diagnosing and treating certain diseases. My assignment was cancer of the cervix. So the radiation oncologist in Salem, her assignment was lung cancer. So all around the state, there were people putting this data together, a priority list of what's the most important, what should you pay for, and what. So there was a list of 700 on the priority. And the idea was that depending on the revenue available, the crossbar would go up or down. And it worked, and it's still working. They're still using this. Well, that's just for the Medicaid population. And now the task force is wanting to do this for everyone. Well, how do we prioritize what we think is important? How important is alternative care, chiropractic? Basically, the bill will cover anybody who is certified to deliver any form of medical care right now. It's not whether certain specialty would include it or not, but it might help them decide how to prioritize services. So that's, I'll try to get that to you through Rick, and hope you can get interested in at least following the task force, and even better yet, testifying.
Yeah, I can just say from personal experience, it's very easy to testify. They're not looking for you to take some of this information we're giving you and try to think of something they don't already know. That's not likely to happen from very many members of the public. But if you tell your personal stories, you know, your daughter or your son lost their insurance, and they don't know how they're going to get their insulin, something like that. Almost everybody has a story like that if they think about it long enough. If not you, a relative, or you know, somebody you care about. So just send those stories in there. It lets them know that people really care about this issue and they're paying attention, if nothing else.
Right. So I wanted to show some other entertaining slides. We have a few minutes. So, you know, we're worried about the lack of trust that the public has in the scientists. And Chin Lee gave a talk at the Adult Lifeline Learning session Thursday about how can science regain the status that it needs. The surveys show that many Republicans trust Trump's view on healthcare more than the CDC. That's pretty miserable position to be in. And Chin's message was that the public, not only does the public need to know about science, but scientists need to know more about the public and how to message to them. So, and I hope everybody can see this cartoon. This would look like a very effective cartoon to remind people that they don't take precautions, you know, 6 feet apart in this dimension. It could end up 6 feet apart in this dimension. So that sounds pretty persuasive to me. But if you're talking with a young audience, the one on the right is likely to be more persuasive. It's funny. It's if you're young, you may not think about death or even that death is possible, but you might be thinking about sex. And so this is just an example of how science needs to learn to message to the public in a way that resonates. I think what's happened since 1900 is science has created its own exclusive feel, even its own jargon that the public feels excluded from. And so when we used to have three classes, the poor, working class, and wealthy, we have four now: poor, working class, elite, and the wealthy. And the working class wants nothing to do with the poor class or even the idea of being on a program that's, quote, for poor people. They identify with wealthy because they could become wealthy through hard work or the lottery. But if they didn't go to college and don't feel they have the option to, and they think these people who did are just full of themselves and telling them what to do, wear a mask, they don't like that. And we've brought it on ourselves, and I think we can recover from it.
Any other questions? Well, we are at 2 o'clock, which is our usual scheduled ending times unless people have questions. So I'd like to thank Dr. Huntington for coming today and for always being available. He's very
You're welcome.
dedicated to the cause.
You're welcome. Thanks for coming, everybody.